afternoon, everyone. Welcome to today's webinar. I would like to remind you that this conference is being recorded. At the moment, all participants are only in listening mode. For those that are connected by telephone and require operator assistance during the call, please press *0. For those online that require assistance, please use the chat box on your screen. I would like to now hand the meeting over to your host, Maria Judd. Please go ahead.
Hello everyone and welcome to today's webinar, which is part of the Canadian Northern and Remote Health Network's Virtual Learning Exchange Series. I'm Maria Judd and I'm Vice President of Strategic Initiatives and Engagement with the new organization, Healthcare Excellence Canada. I'm really excited to introduce you to our new organization today. Before we begin, I'd like to recognize that the main offices of our organization, Healthcare Excellence Canada, which is an amalgamated organization bringing together the Canadian Patient Safety Institute, CPSI, and the Canadian Foundation for Healthcare Improvement, CFHI. Our offices are located on the traditional, unceded, and unsurrendered territory of the Algonquin and Treaty 6 peoples. As I've been taught, a territorial land acknowledgement is an act of reconciliation. It involves making a statement recognizing the traditional territory of Indigenous people who have called the land home long before the arrival of settlers. I'm very grateful for the teachings I have as I'm on my own reconciliation learning journey and the deeper connection to land that I have because of the teachers I've been privileged to be connected with. At this time, I invite you to introduce yourselves in the chat, and if you're comfortable, also to share a land acknowledgement so you know the land that you're joining us from today. I want to acknowledge that we're joined behind the scenes by our staff in our Northern Indigenous Health Program, Despina Papadopoulos and Megan Sambian. They'll be operating our chat box today, and our producers, Sheena and Kelly and Mihaela. I want to encourage you to share your thoughts, reflections, and questions during the chat throughout today's session. We will pause at 3 points to make sure that we have opportunities to pull in your comments and questions from the chat into our discussion as well. It's hard to know who's in the room when we gather virtually, but we did want to share with you that we have a really diverse group of individuals participating on today's session from coast to coast to coast. Many of our participants who've registered are located in the Territories, British Columbia, Alberta, Saskatchewan, Ontario, and Newfoundland. And you've told us that you wear different hats and come from different sectors, including those of administrators, consultants, physicians and nurses, researchers, policy advisors, QI specialists, patients and family advisors, persons with lived experience, and Indigenous leaders. Thank you for joining us. We're really pleased to be offering this webinar bilingually, and if you would like to view today's slides in French, please just let us know using the chat box on the screen. We invite you to use either official language when entering your comments or questions throughout today's session as well. And a reminder that today's session will be recorded, and the slides and the audio recording will be available on our website next week. Next slide, please. So as I mentioned, I'm representing the host organization for today's session, and it's a new organization officially this week, Healthcare Excellence Canada, which has brought together CFHI and CPSI. And we're really excited to be working with you, people across the country who wear a number of different hats and roles in healthcare, in forming policy, in setting policy, in implementing policy and practice, and in experiencing care. And we have a relentless focus on improving care, making care safer with and for more people across the country. We're an independent, not-for-profit charity funded by Health Canada. And we really look forward to working with you to shape the future of care, responding to the issues of today, as we know as the pandemic continues across the country, and important patient safety issues such as racism in healthcare, systemic racism in healthcare, as important patient safety issues continue to need our attention and our response. Next slide, please. Our new organization was formed because we heard from people across the country the benefit of creating a new organization that has a pan-Canadian view, the ability to look across and work across and bring together across the country people working to provide care, and to make care better with and for more people. And we heard many things from people in developing this new organization, and one of the important things was to be bold in identifying innovative and better ways that we could organize, fund, and provide care, to be bold in working with people across the country to move past the status quo, to make our systems easier places to do the right thing, and to make sure the voices of those who our systems are there for, patients, families, people with lived experience and communities, were at the core to what the future looks like. So I look forward to working with you as we go forwards and as we dive into today's discussion. Next slide, please. And I keep going. Next slide, please. Delighted today to be joined by Michelle Stimpson, who's a person with lived experience, and engagement leader, Lauren White, from the Government of Yukon's Department of Health and Social Services. And Michelle, I'm going to see if we can open the line so you can say hello and bring a greeting.
Hi, it's Michelle Haber, and I'm from Treaty 6 Territory here in Edmonton, and looking forward to the panel discussion today. Thank you.
Thanks so much. And Lauren, are you there as well? Would you like to say hello?
Sure. Can you hear us now?
We can. There's some feedback, but we can hear you.
Okay, how's that?
That's better. Thank you.
Okay, there we go. We'll get the technical stuff out of the way. Hi, I'm Lauren White. I'm an engagement leader with Health and Social Services, Government of Yukon, and we are joining you today from Whitehorse. Michelle and I just want to respectfully acknowledge that we live, work, and play within the traditional territories of the Kwanlin First Nation and the Ta'anquachan Council.
Thanks so much for joining us today. So we're also fortunate to have with us family medicine physician Dr. Amy Gosvick and her colleague Michelle Haber, the clinic manager, who are both with us from Alberta Indigenous Virtual Care Clinic. And Michelle, we've had two Michelles with us today, and Dr. Gosvick, just wondering if you wanted to bring greetings or say hello before we get started.
Yeah, hi there, everyone. My name is Amy Gosvick, and I'm a family physician, and I'm coming to you from Calgary, Alberta, and Michelle and I are here in Alberta. Michelle's in Edmonton, and Alberta is the home to Treaty 6, 7, and 8, as well as the Métis Nation of Alberta, Region 3.
Thanks so much, everyone, and thanks to everyone who's introducing themselves in the chat as well, and just invite you to continue to do so as we start to shift into our presentations and discussion. We're really pleased to provide simultaneous interpretation for all of our Healthcare Excellence Canada webinars. Just wanted to let you know that sometimes this results in a bit of a delay and pauses in our dialogue, so stay with us, and we invite you to participate in our chat again in either official language throughout the session.
Can you hear me, Maria? Sorry, can you hear me? We didn't get to introduce Michelle here. There were two Michelles, and I think we missed Michelle Stimpson in that. So if she can just do a quick introduction, that would be great.
My sincere apologies. Absolutely. Back to you, Michelle Stimpson.
Hi. I was born in Alberta in Red Deer, and I've been up in the Yukon for 33 years or so. And I'm grateful that I'm here today in this virtual table sitting with you all and to share some ideas and thoughts that I've had experienced in my lifetime, I suppose, with you. And thank you.
Thanks so much, both. And we're really here, we'll move to our next slide because we have some learning objectives which have guided the planning for today's session. And they really came out of, today's session really emerged from a May, actually, 2021 roundtable of the Canadian Northern Remote Network, which was focused on virtual primary care in northern and remote settings. And we recognize and we've heard from folks across the country that there's really broad interest and growing interest in exploring and understanding promising practices, innovations, and lessons learned and perspectives as we have had this dramatic shift to virtual care because of the pandemic, but certainly the need recognized before the pandemic and will continue past to improve access to primary care and the opportunity that virtual platforms offer to do so. this is the third in a series. Oh, we'll just go back for a moment to the learning objectives. Thanks. Just to say this is the third in a series, and so I encourage you, if you're interested, to have a look at the previous two webinars, all under the overarching theme and through the lens of virtual primary care in northern remote settings. So our first session was focused on cultural safety and Indigenous partnerships. That was in November. And we had colleagues join us from First Nations Health Authority in BC. Our second session was focused on enhancing equity and access. That was in January. And we had colleagues from Manitoba and Saskatchewan join us to share their experiences and models of care. And now today, our third session, we're focused on patient and family-centered care in virtual primary care. So the format for today's session is we'll first hear from Dr. Amy Goswick and Michelle Haber, who will share their experience in leading the initiative to launch the Alberta Indigenous Virtual Care Clinic. Then we'll have an opportunity to take questions and comments that you'll be able to share via the chat feature. Then we'll invite Michelle Stinson and Laura White in the Yukon to speak to their experience developing virtual primary care in the Territory, working collaboratively with and for community to build relationships and ensure that we stay focused on people-centered services at the core of care. And we often hear this is a challenge in virtual care. So I think really looking forward to everyone's reflections and sharing with us that how you can build and ensure virtual care is rooted in relationship and with and for the people that's there to serve. At the end, we have some guided questions, and we'll open up again for questions from you for the chat. So 3 sections to our time today. And at this time, I'll hand over to Michelle Haber and Dr. Amy Goswick to share your story. So over to you both, please.
Thank you, Maria. So we're happy to be asked to speak today, and really honored to give you a bit of our experience of setting up the Alberta Indigenous Virtual Care Clinic. I'm just waiting to see if my first slide is going to come up here.
There we go.
Oh, great. Thank you very much. So as I mentioned, Michelle and I are both from Alberta, which is home to Treaty 6, 7, and 8, as well as the Métis Nation of Alberta, Region 3. We can go to the next slide. So early on in the pandemic, back in March of last year, as things were shutting down and everybody was getting very panicked about what this might mean, especially in terms of being able to access healthcare, there were a few different Indigenous communities and groups that came to the group of doctors that I work with in Alberta and asked if there was any way that we could support them with virtual care to keep their community members safe during the pandemic. They had no doctors that regularly came to their community. Their community members would have to sometimes drive long distances to get to a physician. Sometimes they were in a position of thinking about having to close down their health centers. So there was a couple of these different communities that came knocking, and our group of physicians in Alberta were a group of physicians that are either Indigenous ourselves or have long, extensive experience working in Indigenous communities and being accepted by those communities. And so a few of us had some capacity to start providing virtual care to some of these more remote communities. We realized there was a huge need, and that providing virtual primary care could address barriers that prior to COVID had previously been long-standing. And so we started off in a bit of an ad hoc way where we would give, the community health nurse and the community our phone number as an individual physician, but we realized pretty quickly if we could operationalize this in a bigger way and offer it throughout the province, we could perhaps really address a big need.
And so the physician group approached First Nations Technical Services Advisory Group, which is known as TSAG, to assist with the creation of the virtual clinic. TSAG has experience working with the First Nation community supporting clinical telehealth throughout the province for over 11 years. So the partnership we formed was between TSEG, the physician group, Indigenous Services Canada, Alberta Health Services, and Alberta Health to offer primary care services to any Indigenous person and their families in Alberta, 7 days a week. And we launched the clinic October 28th as a soft launch, and then we did our official public launch on December 1st, 2020. Next slide.
So one of the things that was critical to us was patient-centered care. It's been known for quite a few years now that people in Canada want virtual care. The inconvenience, the time it takes, the cost not just of gas and vehicle, but the cost of having to take a day off work to get to a doctor's appointment is a barrier to getting care. So we knew that making virtual care accessible, we needed to be able to provide appointments in different ways, including not just Wi-Fi and computer-based, but also something as simple as a landline to allow people wherever they are to try and connect with us. And some people have no connection to those. So we also wanted people to be able to connect with us even if they didn't have a phone line or a landline. And so we specifically tried to make connections with the friendship centers in some of the cities, as well as the nursing stations on reserve. So people could use whatever technology they might be able to access from their location. So whether your view out your window looks like the picture on the left in a downtown city or the picture out the right, we wanted it to be easy for people to connect with us.
And just to highlight again, we wanted to reduce barriers people face, such as not having a provincial healthcare number on them or the card they've not in their possession, or they've experienced at going to a clinic that they unfortunately didn't show up for that appointment. And sometimes it's difficult to rebook at a clinic because you did have a no-show appointment or you were charged a fee for not showing up for that appointment. So that may restrict you for going back for service. So we just wanted to be able to allow the people to have that option of rebooking. Sometimes something comes up and you become not able to attend your appointment and the notification wasn't made. We don't want that to be a barrier. And then also taking the time to listen to the patient and get their history and addressing not just one health concern. We know that a lot of virtual care solutions work great for those one-time instances you need it. But there are other times where they may be phoning for one condition, but really there's an underlying issue that should be addressed and someone should take the time to listen to that patient. So that's really important to us, that we're not rushing patients through the door. Next slide.
So in addition to geographical accessibility, we always wanted to make sure that our care was safe and accessible culturally. We want people to be able to access an appointment with a family doctor on the day they need it. So we've made our motto that you can call in and get a same-day appointment with a family doctor. We also wanted culturally safe care that people are telling us isn't always available in their area. So as I mentioned before, our physicians and staff in the clinic are either Indigenous themselves or have lots of experience working with Indigenous health and really embrace that cultural humility.
And they understand those barriers and support challenges Indigenous patients face, such as distance to access service or the cost, long wait times. And for the First Nation patients, the physicians have an understanding of what non-insured health benefits, which is a difficult system sometimes to understand. So for those that have not had the experience. Next slide.
So we wanted to talk a little about relationships. And so this picture is of yours truly, but there's a couple things on this picture that is not the greatest picture, but we've learned from it, and so we wanted to highlight that. And relationships are hugely important to us as human beings, and especially when it comes to Indigenous communities, relationships are important. As people, we are often in a vulnerable and scared position when we have health issues. So we needed to figure out how can we foster that trusting relationship over the phone or a computer with folks we haven't met before, when we don't have a physical presence in their community. So we knew this would be a challenge, and with different doctors working every day at our clinic, we needed patients to be able to develop trust very quickly with our clinic as a whole and with the physician. So to us, this meant that every person the patient interacts with through our clinic exemplifies safe and accessible care, cultural humility, consistency, and reliability. So patients, when they call in, their first point of contact is a medical office assistant who answers the phone, and so those folks are key. And when the patient interacts with the physician, they also have the ability to rebook an appointment or have follow-up with that specific physician later on to have that continuity of care. Our MOAs really do go above and beyond to ensure the patient has the best quality experience. And we also really wanted to make sure that we didn't interrupt the continuity of care if the patient already has a family doctor. So if they already have a family doctor somewhere else, we'll absolutely address their concern, but we always want to send back our notes to their regular family doc so they know what's happened if the patient is agreeable to that. If the patient doesn't have a regular family doctor, we offer to help find them one in their area. And if they still don't feel that that's appropriate, we are able to continue to provide care for that patient and be their most responsible provider within the limits of what virtual care can do. So the one thing I wanted to talk about with this picture, why it was a great learning example for us about relationships, is that early on we had designed this logo, this AIDCC logo, as a kind of a prototype that we started using. And we actually really quickly got feedback from the Métis Nation of Alberta that our logo might not be inclusive to all their members. The colors of the medicine wheel, the feather, didn't speak to the Métis Nation members as a whole. So we were able to work with them and find out what actually would be a more inclusive logo, and we're in the process of changing that right now. So we've gotten rid of that logo, and stay tuned for what our new website logo will look like. Next slide.
So the technology. So sometimes technology is a friend and sometimes it's a foe. So you have to work around that line. So we have a centralized toll-free number to book an appointment with a medical office assistant 7 days a week, Monday to Friday. And we have the option also to put a request on our website. There's a button, you put minimal information in, but that would get you a call back from our clinic. So if you're having something late at night and you just need to reach out so you have a phone call first thing in the morning, that is an option. Or if you're more comfortable submitting your request online, that is an option. We give the patient the option of connectivity, either through the phone or video appointment using their own device. One of our greatest challenges is connectivity, unfortunately. We all wish we had super speed internet everywhere and cell phone towers every few kilometers, but unfortunately that is not the case. So we do have patients that have landlines, and those work really well. The old school technology does work, but we also have patients that have cell phones, and connectivity can be a little broken sometimes. Sometimes they have to drive in their car to get better connection, or sometimes they have better internet services available in their home, and we use those to connect the video appointment. So we're very flexible with what the patient has, and we do have the ability, if they live on a reserve, to go to the health center and use the technology that's available there. We've also partnered with or spoken to a lot of the friendship centers and shelters, and they're willing to use their technology to allow patients to access that information or our service. So, and then one of the benefits of using technology is that the patient has the ability to bring in extended family or support into their appointment with them by phone or video. We have both options. We are not limited by the room size or temporary restrictions of the hospital that might be in place because of COVID, or the location of where that family member is. So if you have a family member that wants to attend this appointment with you and they live in Ontario and you're in Alberta, that's possible. So we feel this is really important to meet the needs of the patients and to help them with their health care. And
So next
Amy,
slide.
do you have
Oh, go ahead, Michelle.
I was just going to say if you had anything to add to the technology.
No, I think you covered it all well. So this is just our last slide. This is our website. This is our 1-800 number, and that's our email address if anybody had any questions. And we're happy to answer questions that are coming in the chat.
Thanks so much, Dr. Gusick and Michelle, for sharing your experience of how you reached out and developed and are continuing to respond to what you're hearing about what's working well and how to make it more reflective of the people that you're there to serve and improve access for. Just going to pause for a moment and invite folks who may have questions for Dr. Gusick or Amy to share them via the chat right now, or other reflections or experiences that you might like to add to the conversation. And I see there's a few folks typing, so we'll just pause for a moment while those come in. Maybe just while we're waiting for the questions to come in, I'll ask a question of you both. What was most surprising to you about your experience in developing Alberta's Indigenous Virtual Care Clinic?
How much there was to do, I can't lie.
Yeah.
There's a lot of things to keep in mind when you're starting a clinic, but I guess the acceptance from patients has been really positive and from all ages, right? So I thought we would probably have a very large acceptance from the age groups of, teenagers to, 60 maybe, but we do have quite a few seniors using our services, and they feel that they have that ability to reach out and get care. So,
I see one of the questions here is, do you have a measurement framework to assess patient-reported outcomes or patient experience? Yeah, that's a great question, and that's something that's really important to us and critical to us. So luckily, Alberta Health Services has a scientific office whose full purpose is doing these types of really validated and extensive measurements. And so they are working with us, and they are creating a great evaluation process to guide us as we go forward. So yes, it's in the works. It's very deeply in the works. It's something we're committed to, and we can't wait to hear what feedback that gives us.
And I guess the next question is, do you have a resource library of professional curated materials for patients to access? And yes, we've started building a resource center on our website, so you can search different topics or just scroll through the list. It's building. We just started building that resource center, so over time you'll see that grow as well.
One of the fantastic.
So you had asked about what was surprising or what did you learn, and so initially the concept seemed so simple, right? Like, let's get a 1-800 number. We can schedule our docs to cover it 7 days a week, and Bob's your uncle, right? Like, we can go ahead with this. And then as we started diving into it and realizing the complexity of it, of setting up a new clinic from scratch, right? And the privacy impact assessment details that you have to go through, it's a very complex process setting up a new clinic just in and of itself. But then a new virtual clinic, which is something that a lot of the regulatory bodies had never dealt with before. So very basic things, like in order to get, authorization to access some of the online lab results, you needed to have an actual physical location of where the doctors work, right? Because nobody had yet entered into this virtual world of virtual medicine. So it's been very interesting. But one of the things early on that somebody said that stuck with me is, you know what, we know we're not going to get it perfect right off the bat. This is going to be an iterative process. We're going to try, we're going to keep going, we're going to get feedback and rejig it and rework it as we go. It's not perfect. It'll probably never be perfect, but we want to keep working at it. So that's kind of our guide.
Yeah, no, thanks so much for that, Dr. Gussick. And as you and Michelle have shared and others have shared, I think some of the most promising examples we've seen in this rapid shift to virtual care have taken that kind of iterative quality improvement approach, right? We're going to build it as we can. We'll address the challenges and be open to the opportunities and the feedback of providers and patients and communities to improve it continuously as we go. And even your comment that we are building the resource library for patients because we've heard that's something that's going to be helpful. So we're building that as we go. And just a huge appreciation to everyone who's been made that shift into the virtual world and are thinking about how do we continue to improve that at the same time providing the care in virtual platforms and in a virtual world. There's a couple of other questions that maybe we can pull in. There's a question wondering if there's somebody who has the role to support patients who are having trouble making the virtual connection, so who have virtual connection difficulties.
So our MOAs are super users, so they're able to troubleshoot a lot. I have an IT background and telehealth background, so if there's additional issues, I can get involved as well. And we do have a technical support team from TSEG as well, so that's part of that partnership.
And is that
one of the things?
Go ahead.
One of the things we've learned and love seeing is, you know, when one of the benefits of being in an intergenerational home is grandma has her grandson there to help her connect with his iPad, right? Like, it's really amazing how great families are at helping each other learn to connect virtually. It's such a blessing.
I'm going to take one more question, and that is wondering, are you able to enable translation needs for patients at all? I think in terms of offering services in different languages.
Yeah, so this is something we are working on, and we wish we had more of this. We had hoped through Alberta Health Services, through their connection with Language Line, that we could use, at the very least, the Cree translation that Language Line offers. But we recently found out that they currently don't offer any of the translation or the Indigenous languages through Language Line, apparently not even Cree, we were just recently told.
Oh, it's lost Amy.
Offer to try and help us with some of their...
I've lost Sam for Dr. Gussick. Michelle, are you able to hear her?
I couldn't hear her either.
Oh, sorry. Can you hear me now?
Yes, I can.
Yes. Okay, so I was just going to say Métis Nation of Alberta is trying to figure out how to help us with some translation services for their members.
Okay.
And also,
great.
we're very fortunate that some of our patients do have family members in their household that can translate for them as well. Or if they happen to be at one of the health centers, generally there's someone that can translate. But that is something that's important to us, and we are looking for a better solution.
Oh, that's great. Thanks so much, Dr. Gussick and Michelle, for sharing your experience developing and clearly implementing and continuing to develop and grow Alberta's Indigenous Virtual Care Clinic. And thanks for the questions that folks on the line are offering, and also invite you to share any of your experiences in creating and helping to improve virtual care. We're going to move on in our time together, and I'm going to turn over to Michelle Stinson and Lauren White in the Yukon. So over to you, please.
Thank you, Maria. Can you hear us okay?
I can.
Okay, great. Thank you. So thank you for having us. Wow, that's a tough act to follow. That sounds like an amazing program, and Michelle and I were just saying so many of the things that Amy and Michelle were speaking about. Some of the barriers really hit home and are very real for us in the Yukon as well. So I thought maybe I would just start really briefly with talking a little bit about the Yukon and our geography and our population, so participants can kind of see some of the barriers we're dealing with. Then Michelle and I are really just going to talk about our relationship and where we are sort of coming from and where we are today. And I'm really going to hand it over to Michelle to talk about her experiences accessing care, virtual care, what she feels the barriers are, and what really needs to happen to overcome some of those barriers. So the slide we have is of the Yukon, and it shows the traditional territories of Yukon First Nations. So our territory size is just over 480,000 square kilometers, which is just slightly bigger than Sweden, to give you a little bit of an idea. Our population is around 40,000, whereas Sweden has over 10 million people. So we are very big and we are very spread out. 70% of our population lives in Whitehorse, which is our capital city and the only city in the Yukon. The rest of the 30% of the population is spread out in our communities. They are on the map. They're a little tough to see. We do have one fly-in only community, and that is Old Crow, and it's up in the very far north. We also have 14 different Yukon First Nations, and who make up about 25% of our population. So that kind of gives you a brief idea of some of the services and what we're dealing with in trying to get those services to communities, and even in Whitehorse. Amy was talking about, and Michelle, some of the geographical barriers. We also have those. We have a lot of snow in the winter, which can restrict highway driving. We have people in communities that aren't able to drive to Whitehorse. We also have, as we said, we have 14 different First Nations, so we have cultural safety barriers. We also have internet issues. We have very unreliable internet at times, and it's quite expensive. So those are some of the things that we deal with, and I'll let Michelle talk to some of the issues that she sees. Really briefly, my job is an engagement leader, so I work for Health and Social Services. And I work with people with lived experience, which are clients, patients, family members, caregivers, anybody who accesses health and social services in Yukon. And in late 2018, our department actually went through a comprehensive review, and in 2020, Putting People First report was put out, and it can be found online. It has over 70 recommendations on how we can improve our health and social services programs and services, and our Minister, Pauline Frost, accepted all. And one of those recommendations is to develop an experience and engagement team to really ensure that Yukoners are involved in the development and implementation and even evaluation of our services. Fortunately, I was brought on as the engagement leader about a year before that recommendation came out. So Michelle and I had already been working together and had already started some of that work. So I'll pass it over to Michelle. I met Michelle when I was very first starting as the engagement leader, and brand new and a little nervous, and that was about a year and a half ago, and Michelle and I met at a training, and that is where the relationship started, and we are here a year and a half later, and I think we've made a lot of really great developments. We've also learned a lot of lessons. We always say they're not failures, they're lessons, and they really are. We've learned a lot. And so I'll really pass that over to Michelle to speak to her experiences.
Thanks, Lauren. I want to say hi to everyone and be part of this is very interesting for me because my angle is going to be quite different than most of yours because my ground level of experience. And that's exciting to have a voice, and I'm waiting for more to be on my team, I guess I could say, as lived experience people, because that doesn't exist yet, and that would be very exciting for me to have that kind of support, although Lauren and I have developed a relationship over this time. And that has really inspired me to be part of this because it's about relating and taking a chance of trying something different. I met Lauren, as she said, about 1.5 years ago at a training, but I was actually a patient in therapy. And I come from a mental wellness background, living through some trauma as a child. So my relationship to the Yukon has become one of a passion for this land and for the people and for the lifestyle. I admire the people that live up here and in Canada, generally speaking. So what have I learned? I've learned that we don't have devices, really. We don't have a lot of ability to get to centers to find virtual communication. So I'm ground level, feeling that getting those devices may be the first step. The language of computer and technology is part of that step. We have 14 First Nations here in the Yukon. That means there's 14 possible language barriers. I consider them to be actually the best thing about our Yukon, because this language about technology could be a game changer for all of us to heal. It's a language that all of us need to learn and to share together. I met an elderly through the engagement experience that is a computer whiz. And what a shock to know that it's not really all about the youth, that our take on life isn't, generally speaking, what we really may think it might be. And that little window for me of knowing that our community in the Yukon might just be a little bit of an experiment to see how virtual communications can really exist with such a vast amount of area, a smaller amount of population, but really a passionate group of people. And not to be lost in those numbers of power and ability and entrepreneurship and ideas. I mean, this is a very powerful territory, and I think if anyone hasn't been here, to come up and check it out. So where do I go with this? I keep hearing things like the needs and people relating. So how do we do that? And I said to Lauren, you know, we need to take maybe the old route to get to a new route and take ourselves mobile and start, well, we only have 40,000 doors to knock on up here, but talking to where everybody may be at. And we don't have communities that have centers that people can maybe get to. We have a large amount of addictions and misuse of opiates and other struggles that all communities are, I think, having a hard look at, might be dealing with. Up here in the north, it might be more prevalent. I'm not sure. I haven't left the Yukon in quite some time, so I'm just going to deal with what I know here, and that's what I'm feeling is here. What do you think, Lauren? You know, I look at this as a relationship and relating building experience for people in the north with virtual care. It's a new take for some people to get computers or devices, iPhones. We were talking about economics. What does it look like to have dad up north for $200 a month? Is there subsidy? Is there ways to get laptops? We're doing programming with elders and the Golden Age Society to get a refund on 75% of a device. These initiatives need to be also part of virtual care, I believe, just because they're the utility or the essential, what am I using here?
Yeah.
The utensils to get this information?
Yeah.
And to be really clear on that, being not just necessarily being so surprised that youth might be the only people needing this, but so many elders are learning these technologies, and giving out phones to the vulnerable sector in this community has been a real eye-opener of how many people really kind of believe that they might not be needing a computer or an iPhone because they've gone so long without that technology. And I myself just learning that a virtual call to my doctor is actually a virtual experience. So that language was new to me, and I just thought I was making a phone call. But there's language involved here to make me understand how much more I know than I actually thought I knew, which is empowering to know that I'm not way behind, even though I haven't left town in a long time to the world of technology. It's coming to us. That's exciting, you know, that's so exciting. Teaching and training people to be mindful, I think, is your frontline bottom need. So that first initial communication, I think, Amy, you're right, has to be a person that is aware of sensitive topics maybe and that training isn't just intellectual. That is a dialectical behavioral therapy training, to be honest with you, to change the way we've been trained and taught in our lives. It's not intelligence. Trust me, I've battled that one. There's some conditioning that you just need to be kind of retrained on, and that could be the mindful part of I've learned in COVID days that we might not be as mindful as we wish we think we are, and that might be just kind of essential.
Yeah, I agree. Like, I think, and I won't speak, there is virtual care going on in the Yukon. We're not the experts, so we're not going to speak to exactly what's going on, but I think what Michelle's saying, and I agree, is there's so much potential, and with the barriers that we were talking about, there's so many opportunities with virtual care, but I think what Michelle's saying is there's a step that needs to happen before that, where you're connecting and where those relationships and trust are built, where people may even feel comfortable saying, I don't have a device to do this, or I don't have money to pay for the data, or etc. And it almost, I feel like we have to, as providers, meet people where they're at, go where they're at. Actually, I mean, COVID made things a bit more difficult, but going to communities and really finding out what they need to support that virtual care so that it's optimized and used and actually helpful. And we, as the providers or we don't know what is needed, and every community is different. We have 14 communities, and it's different. So I think what I'm saying is that this all sounds very exciting, but what are we missing in between?
Yeah, to get from here where we are, I think, to go where maybe you are in Alberta is to take these smaller steps. I also think, truthfully, that mental health is a discipline that we don't equalize in our world of medicine, and I'm not sure even today how we feel about making that discipline an equal member of all disciplines in the world of medicine. That's my struggle right now, is to put mental health on that top, right, actually past the top, and just really honor that and represent that mental wellness for all of our communities. That clearly is my big passion right now. I have a rare blood type. I have other medical things going on, but the mental health right now for me is the biggest department, I think, that I would like to really tap into with everybody, get that acceptance level up really high, and the shame of not having a device or your economics or your generational past kind of gets maybe dissipated with some mental health treatments, or less shame involved with going to that mental health sector. You know, there's so many things about stigma and stereotypes that we can't really get past until we get there. So it's hard to talk about, because I've done 3 years of some intense therapy, so I've done some work, and until you do it, it's really hard to talk about the other side of that. So I'm kind of done with my story, my share, and I really appreciate you giving me some time and a space here today.
And, and thank you to Michelle for joining us. Like, really, she has been, we always say we're partners, we are a team, but that took time. We've known each other for 1.5 years, and I think that part of engaging with people and communities, part of the hard part is it really is time to build those relationships and that trust and get to know each other and really trust the intentions and how do we work together and build the honesty. I think one thing I appreciate about Michelle is that she's honest, and that's what when I'm showing her, what do you think of this flyer, what do you think of this, and she hands it back to me basically ripped into shreds. I appreciate that, because your experience and your expertise are what are going to make us really connect with Yukoners. So we are a team, and we are friends, and that does take time. So
I kind of see our relationship kind of like the virtual introduction to the old days of maybe not having that option. because I met Lauren in fear of how she would see me, and I believe that's how she met me, because I, really feel like the time that we have developed is not something you can just eliminate and expect that relationship to be any more better than it could be just in a few minutes. It took time. So fair enough to that, and I honestly was so impressed that Lauren called me her friend the other day, that developed out of us meeting in a very timid and almost like a not want to meet situation to a, wow, I think we can change the world feeling. So that's amazing to know what we can do, and putting the time into it really is powerful stuff.
And I think going out of your comfort zone, at the beginning, Maria had put up a slide with, and one was to be bold in your actions. I think you do. You have to put yourself in uncomfortable situations. And Michelle, like she said, when we first met each other, we didn't know anything about each other. And Michelle invited me actually to come to lunch at a women's group that she went to. And I had some fear going. I didn't know, would they think, who is she coming to this? And when Michelle first came to the office to meet, I think she felt similar.
Yep.
But the trust and the respect, and that we both have the same intention, that we are going to change the world, that's brought us together and really made this work. And
I don't think we can actually separate the fact it took time.
That's the number one thing.
Time.
That's the number one thing.
Yeah.
And I hear Michelle asking that, she would like to have more of a support of having more people with lived experience, and that is absolutely what we are doing, and we are working on in the engagement and experience team. And we do have other people with lived experience, and so hopefully with time Michelle will feel that sort of her support from that group, definitely. So I think that's about what we wanted to say. I want to leave time in case there's any questions or anybody had anything they wanted to say.
Thanks so much, Lauren. Thanks so much, Lauren and Michelle. And I just want to pull up, because I know when you're presenting and sharing, it's hard sometimes, or maybe I find it hard just to keep an eye on the chat as well. And so, comments coming in, first of all, really thanking you, Michelle, for being part of this conversation and really supporting that we need to, when we're thinking about any kind of new ways of organizing and providing care, we need to be talking with and working with people that the care is for. So just real support for growing your team, as you said, and for all of us working across the country and in different settings to improve virtual care, virtual primary care, any redesign improvements in care of that partnership. And there was a slide up at the beginning, and Lauren, you related to, we had titled this session patient-centered, patient-partnered care, lots of different ways people are framing patient engagement, people-centered healthcare, but really at the core it's about the partnerships between people providing care and people are looking for care. And so I think with people with lived experience of our systems who can bring that really important perspective to where we can make things better for experiences and for outcomes for all. So thank you for joining. Also, a lot of support for saying, yes, changes in mental health are needed. Coming some examples in the chat of some different initiatives, different parts of the country in response to that. And I know there's been a lot of apps and others developed that don't replace relationships, but a part of the virtual explosion that we've seen. And Michelle, thanks so much for your comment around, virtual care, right? That includes phone calls. Just being clear on language, that we're making sure that we're clear what we're all talking about and we're building a common understanding going forward. So I have just lost my connection to the chat, so I'm going to ask if there are other questions coming through for Michelle or Lauren. We can go to those at the moment.
Trying to read and looking at here. I think there was a question. Did you grow up in the Yukon, and how have you seen healthcare change over time?
That's for me. My name. I was born in Red Deer, Alberta, and I spent a lot of time in Drumheller. A teenager in Kelowna, and when I was 23, I moved up to the Yukon, and I haven't really left except once. So have I seen the healthcare change system change in the Yukon. Yeah, less doctors, more people. Yeah. A lot of deaths with opiates in the Yukon. I think with the medical, and again, I found medical and mental health is a combination, but I think that's going to change over time. That's my answer to that question.
I was born and raised in the Yukon. I grew up in Haines Junction, and I've seen changes, and over time, it's hard to say back. There's definitely been some virtual changes and whatnot, but I think one thing that stayed the same, and maybe I just focus on it from a community, is the importance of the community health centers and the nurses. That's always been very, because we are so spread out. I think that the nurses and the nursing stations, the scope is, they deal with a lot of physical and also mental health as well. So, yeah, there's been changes, but if that's an answer, but I think what doesn't change is the people that live in the communities love the communities and don't always want to leave the communities, and so that hasn't changed, that they really want the services coming to the community. Yes. It absolutely makes sense and is what we are trying to do the best we can. Yeah.
And would you say there's mobile going out for communities now to do the vaccines, and
yes,
that's gone on the road. So
yeah.
Those trips have given a lot of the smaller communities some safety, because this is also a border community with Alaska, and so Beaver Creek and Watson Lake, where there's a lot more communities traveling within each other, those protections have existed. That's awesome, right? So we know there's mobile ability, and that's kind of nice to. I was saying to Lauren that it'd be sweet to get our youth back into being trained to be in the medical field, and then come home and then start knocking on doors and being those doctors that used to come to houses if they have to. I know that's a big, weird step in a way back, but when you live in a remote town like this place, it sometimes seems like a good idea. Who knows?
Well, thanks so much for those reflections. And I think, just speaking on, have you seen changes in some of your comments that shared? This question, I think, is for any of our 4 members, our panels, our guests today. Question from Moira at CMA saying the turnover with doctors is something we hear about. And what are your thoughts? Do you think virtual care might help retain more consistency with physician care? Maybe I can start with you, Lauren, and then go to Amy.
Sorry, could you just repeat the question? It blanked out for a minute there.
The question is questions from Maura at, I believe, Canadian Medical Association, and she's picking up, I think, on the comment about doctors and the changes that you reflected on. So it's saying, do you think virtual care might help with retaining doctors and provide more consistency?
Yeah, I'm not an expert on that one. I wouldn't know. I don't know retaining doctors with virtual care. I think where we I don't know. I'm not the expert on that one. I don't know, because I think where Michelle's comment about doctors, it does relate to Whitehorse, but also the community. So if we were trying to recruit a doctor to a community, I don't really know much about virtual care would really,
I don't know either,
be something that would be attractant for them.
Sounds like Amy would know this.
Yeah, that's maybe more of an Amy question. Amy.
Sure. So yeah, doctor turnover is something that's really difficult, right? And some communities survive exclusively on rotating locums that come in and staff their health center. And that's really difficult for the patients, right, to see a different doctor every time. So one of the benefits that we hoped our virtual clinic could provide is some consistency for folks who wanted to use our service. So whether they live on reserve and use us as their main clinic when they're on reserve, and then they move to the city and go to school, and we're still their family practice clinic, right? And then maybe they move somewhere else for their job in the province, and we can be their consistent family practice clinic. There are definitely, though, some concerns that physicians have about virtual care. One of the concerns our physician group has is, will this virtual care and the benefits for physicians of virtual care mean that less physicians are actually going to go and work in those remote communities? And is that going to mean that funders like government are going to say, well, we don't need to actually put a lot of money and recruitment into funding these remote healthcare in these remote positions because they've got this virtual clinic. That should be good enough, right? So these are real worries that we don't have the answer to yet, and we struggle with, right? We struggle with knowing what's going to happen.
Yes, thanks for those reflections and important questions we need to wrestle with as we think about that shift from a system perspective and individual providers and patients and families, communities, for sure.
And I think we also have to mention that virtual care is not the answer for all types of physician visits, right? You still need to have some of those in-person physical examinations, appointments. So this is a choice for certain kinds of situations, right? So.
Yeah, I would agree with that as well. I mean, it would be wonderful to have on those times, when people can't physically drive into Whitehorse to see their physician. That would be it would be wonderful to have, but I agree with what Amy and Michelle were saying, that it's not something that we would want to replace at all. Yeah, we still need that extension.
I think that's a theme I'm hearing in a number of conversations, that virtual care is virtual is the tool and opportunity to care. It's not the replacement for all opportunities for interactions with providers. And going back to our questions, there's a question, and perhaps Lauren and Michelle, for you about how your experience, could you share your experience about how you reach out to mental health clients and engage them in some of the work that you've been doing, and specifically if you have an example or a connection, and then what was the result of that and being able to reach out and engage in perhaps a project or an improvement that you've been working on or focused on.
So do you want to?
Yeah, I'd like to say a little something on that level. So after leaving therapy, realizing that I didn't have a cell phone and decided I was a person that maybe never needed a cell phone, I actually got a cell phone, and then it was not a cell phone anymore. It was done as far as data goes. And then working with the community in a few months, how do I explain it, to reignite the phone program again, and meeting so many people with mental health that I have met at the shelter. To be honest with you, I live right directly behind our emergency shelter here in the community. Mental health doesn't give you a career. I ended up in poverty, so my struggle with working and meeting these people in my community after being here all these years was interesting to me, and still is actually. So where am I going with that?
How do we connect?
So going to the shelter, going to where people are, has been my pull from, I don't know how many times. Lauren was the first one to take my bite, if you will, bringing her to a women's center where women are abused and mistreated and sometimes harm themselves. So she took a step out of herself to come to a place that I had to take a step out of myself to go to out of need, and she came and checked it out with me. Getting people out of their offices and where the people are, to me, is kind of like the answer to any question about where they are and how to get them. You go there and you meet them and you talk to them. And I can honestly say, in the 33 years I've been here, I've never met such a diverse, awesome group of people at the shelter. I've never seen more death in my life, ever. I didn't know that many people died here. All the years I lived in a different part of town, I think 2 people died that I knew. Over 20 in the 3 years I've been downtown Whitehorse have passed. That has been such a game changer for me to get this data out, to get devices out, to give people an opportunity to play on the game level of equal opportunity. I'm huge about that. I'm huge about going to where the people are, because that's how I got my life transformed, by ending up in these places out of circumstance and out of whatever I've been through. But it's been amazing. You've got to get out of the office and go to where people are. That's my answer to that, big time.
Yeah.
Big time. And not to be afraid of language barriers or cultural values and differences. That's what every Canadian's about that. We're about being different. So I like to embrace that and say, yeah, I'm different. So do you like tea or coffee? Something's got to go, you drink something. There's a common thing right there. We just have the drink. That simple stuff seems a little bit ridiculous maybe, but that's how trust happens. That's how trust happens. I think so.
Yeah, no. Thanks, Michelle. I think an important call is people in healthcare environments, whether that's clinics or hospitals or community centers, think about wanting to hear more from people who have lived experience to think about where are people, and to go to where they are. So where they are, a great call for people looking to partner with people with lived experience. So thank you for that. I'm going to go back. There's a question that's come in. I'm going to ask Dr. Goswick or Michelle Haber respond. You talked about the goal of the virtual clinic to provide culturally safe care. And I talked about how some of your providers may share the same cultural background as some of the patients and families, communities you're serving. And I guess the question is really about how do you help enhance and support culturally safe care through your virtual clinic? Is there formal training, or what does that look like? If you could share a little bit with us about that.
Sure. I can start, I guess. AHS is allowed our staff and physicians. The physicians are part of AHS, but there's an 8-part series on culturally safe Indigenous health, and that we have access to watch. We're just waiting for the new launch of that series. And then we've been looking at different areas where we can get additional education. So Métis Nation of Alberta is willing to do a presentation to the team of all the physicians and let us record it. So those physicians that can't attend at that time would be able to attend the session, both from a historical perspective and then also how Métis interact with health and some of the barriers. And so it was really important for us to keep those connections. We've also reached out to some of the other supporting agencies that are in both Edmonton and Calgary. So we know the importance of making sure that our staff are getting regular intervals of education.
Thank you so much. And Lauren or Michelle, Yukon, anything you'd like to share or add to that?
From an engagement, did you want to?
No, go ahead.
Yeah, just from an engagement level, if I was going to be working with a First Nation program, something like that, we would do a lot of work with the hospital and the First Nation Health Program. Because we engage at an individual level, I would be looking to people with lived experience and actually what would make you feel safe. Is there training? Do we need to work on some script with the providers? Just basically, I would ask them because they're really going to be able to let us know, and then we work and try to overcome those barriers if there's anything that they need to feel more culturally safe.
A great reflection in terms of, asking, and then also people telling us, when they feel culturally safe. That's when we know that culturally safe care is being delivered as well. I know there's been lots of talks about, metrics around that, and that's important as well, but asking people, I think, is very powerful and important, absolutely. We did have I'm going to invite folks who are on the line with us to just, again, share questions or examples or resources that they may have around any of the themes we've been talking about. So creating and improving access to care through virtual means, partnering with people with lived experience in communities and in creating those opportunities and those services, thinking about enhancing cultural safety and humility in care interactions and experiences. There's a few resources that have been shared. We did share the link to the Alberta Indigenous Virtual Care Clinic that Dr. Gosvick and Michelle Haber spoke about and in the chat feature, and there were some examples being shared from other places across the country as well. We did have a couple of discussion questions that we also thought might be helpful to pick up on. We've sort of touched on a few of them, but maybe I'll just ask the team to bring up that slide now as well. And we'll continue to look for other questions that may be coming in through the chat as we move towards wrapping up our time together today. Oh, there's a question that's come in. Maybe we'll start with the team from Alberta and then I'll turn to the Yukon. Somebody's asking, have you had any feedback about people feeling more comfortable in various virtual health appointments when they join from their own home, from their safe space?
Sure, I can speak to that. So previously, before virtual care was really easily accessible, I think a lot of us as family docs, myself included, thought, oh, people really value that in-person, face-to-face relationship with their doctor, you know? They really like that. They really want to see us in person. They want that human touch. And that's true for a lot of people, but what we didn't realize, because it wasn't an option before, is that there is some people that actually, that's a really intimidating thing. And so there are people who actually feel way more comfortable engaging with healthcare in a more perhaps anonymous way over the phone line, right, from the safety of their own home, and especially around some of those more stigmatized issues. So I work in the First Nations community, and there are folks in that community who will never darken the doorway of the health center. But once we started having phone appointments regularly, these patients will call and talk to me about their addictions issues, right? Because it just feels more safe. And that's a really neat realization I've had with virtual care, that, yeah, we actually can reach some people that we weren't reaching through the traditional models.
And I think also for some of the more sensitive topics where someone might feel more uncomfortable talking about something that's happened to them or a symptom that they're having, not having to face that person in front of you to say the issue is more comfortable as well.
Benefit. Lauren and Michelle, anything you'd like to add from your experiences and what you've been hearing from folks in the Yukon?
I think when I hear the word safety in home, I'm not hearing the same unsafe homes that I know exist here in the community with COVID and so many people having to stay home in abusive relationships. And I don't want to miss that because it's really relevant to me to acknowledge that. So there is safety, I know, calling from home. I'm one of the people that was afraid to go to the doctor's office even before COVID with my mental health, a little bit intimidated by crowds and whatnot. There's also that issue, though, about being safe at home. Right? Like being safe with your partner and being, now how do we do that? How do we, how do we look at that for real? So that the word safety at home isn't lost in the fact that maybe it's not safe to be at home. That's what that brought up for me, and I don't want to ignore that, bringing that feeling up for me. But what do you do with that? I don't know yet what to do with that. I kind of want to put a video in everyone's home, but you don't do that. That's not nice. But safety, what is it really, right? Like, let's really not fluff it up and making home safe. That's, like, not for everybody. That's all on that.
No, thank you so much for that, Michelle. And I think just the importance of remembering that everyone's situation is their situation as we think about the impact of virtual care. Appreciate both, the reflections, what that means for people. And safety can mean very different things for different people, and being responsive to that. So thank you. There's a question for, again, Amy and Michelle. did you approach the Council of Elders for Community? Sorry, did you approach the Council of Elders for the Community in terms of buy-in for virtual care? And the person asking the question is sharing that says, we're struggling with engaging Aboriginal communities in our area. So I think you had shared maybe a little bit at the beginning of your presentation. Maybe you could elaborate a little bit about what that looks like for folks.
So from a governance standpoint, Alberta has co-management, health co-management. So the clinic was brought forward to the Health Co-Management Committee and was approved through that means. And then I think we've had discussions with the Indigenous core within Alberta Health Services where they have a wisdom council, but maybe Amy could address if it did go in front of the wisdom council, which is a group of elders and representation.
Michelle, can you just describe a little bit about what the health co-management is in Alberta? Because I suspect people don't know what that is.
Oh, sure. Health co-management, I'll try, is a relationship that the First Nations have representation on every committee, and then the federal government has representation. So the health co-management is a decision-making body that decides how funds and actions and priorities are brought forward and then voted on, and who has the priority to move those motions forward. So there's a health co-management board, and then they break down into, I believe, 7 subcommittees. So into mental health, primary care, operations and support, and I'm probably forgetting some. So I apologize, but there is an HCOM website as well to look at.
The other piece that's important is that this whole idea for the virtual clinic went to the board of directors of TSEG, and the board of directors of TSEG is made up of chiefs from all 3 treaty areas. And so in that way, it had some Indigenous leadership approval. Now, did every Indigenous community in Alberta get consulted before this clinic was started? No. This was a COVID response and a quick setup, and so we're still in the process of getting feedback and engagement from various stakeholders and various communities. The other piece of this clinic that was novel is that it wasn't just meant to be set up for First Nations on reserve patients. It's meant to be non-status, off-reserve, Métis Nation, Inuit, however people identify, and also their families. So we have a huge stakeholder presence to engage with and get feedback from. And so, yeah, the process, of course, hasn't been exhaustive because of the timeline, and we're still working on that, getting more and more consultation as we go, trying to find the needs of all of those stakeholders that we hope to serve.
Thanks so much both for sharing. Oh, and hello, we've had another person join us. Welcome.
Hi. Oh my gosh.
Thanks for sharing your experience, and I think also too, encouraging to understand what are the formal structures and informal structures that may be in place in various contexts and regions across the country, and opportunities to connect with First Nations, Métis, and Inuit partners and leaders. There's one other question I'll pull in, and then I'll thank our speakers and thank everyone who's been joining us today. There was a question wondering, I think this is a question for our colleagues from Alberta. Can you speak to the ratio of sort of proactive or preventive care versus reactive care that you're seeing in your virtual care clinics?
Oh, maybe. Amy, are you going to take that one or no?
All you, Amy.
I would say, yeah, the vast majority of the calls we're getting at our clinic are acute issues, reactive issues, wanting advice especially about COVID. We're getting lots of appointments, people having concerns or questions about COVID. Very little preventive care. But I think we also, on some level, know that preventive care is something that you prioritize more when all the other social determinants of health in your life are optimal, right? And so we often see that preventive care for many of us is kind of at the bottom of our priority list. And so it's not a surprise to us right now that a lot of our questions calls are more reactive or acute episodic care. We'd like to change that, right? From a healthcare standpoint, preventive care is so important.
Thanks so much. And I love that our virtual circle is widening with your son joining, looks like you're a little one on your lap there, and a pet looks like has joined you, Lauren. So just welcome to everyone who's joined our virtual circle today. So just thank you so much, Michelle, Lauren, Amy, and Michelle for sharing your experiences today and responding to some of the questions that have come in. Thanks everyone who's joined us and shared questions and reflections and resources via the chat. I want to thank again the team at Healthcare Excellence Canada who's helped organize our webinar and our virtual discussion today, Nicole Despina, Megan Mihaela, and Rebecca, and of course our Canadian Northern Remote Network members and our planning committee for today. Just reminding folks that the recording will be available of today's session on our website next week. And your feedback is really important to us as we think about future programming and potentially expanded programming and support for virtual primary care and other webinar topics. So we're going to put up in a moment a few questions, evaluation questions that we invite you and ask you to give us feedback on today's session, as well as any other suggestions you have for future programs, education programs, support for evaluation and measurement, the different aspects as we understand what better care and safer care looks like as we go forward. We do have a couple of upcoming opportunities that I wanted to draw folks' attention to. They are on our website as well, but we are running a series it's called Long-Term Care Plus, and it really looks at sharing early lessons from the pandemic, about organizing and providing care in long-term care and retirement home settings. There are 6 promising policies and practices that is based around, and we have a series of national huddles, opportunities to hear from folks across the country responding to and preparing for COVID and non-COVID care for people in long-term care and retirement homes. So that session continues going forward, and more information is on our website, as well as we have a session on community dementia care and support, looking at emerging innovative models and best practices, coming up in March, April, and May. So thank you again so much for joining us today, and we hope that you will take a few moments and give us some feedback on the evaluation form that's coming up on your screen in a moment before you sign off. And that concludes our session today, and we wish everyone a safe and healthy Friday and weekend. Take care.
Thank you.
Thank you.
Bye-bye.
This concludes today's webinar. Thank you, everyone. You may now disconnect.